Shalin, welcome to the Optimal Performance Podcast.
Thanks for having me, Sean. Looking forward to it.
So, if you would just give everybody a high level introduction to yourself, people describe themselves and introduce themselves better than I could ever do. So, just tell people who you are, what you do, and where you're coming from.
Yep. So yeah, Shalin Shah, I'm the CEO of Marius Pharmaceuticals. We are the manufacturers of KYZATREX, which is an FDA approved oral testosterone. So I've been in the space for 10 plus years here, focused, directly on testosterone. I have an investment background, looked at all sorts of companies and, from the investment perspective, also operationally gotten involved quite a bit. But I think this is a real special project. Again, it's been 10 years. Oral testosterone at that time was notoriously hard to crack. I think, even though it's come a long way as a therapy, I think there's still a lot of misconceptions around testosterone. I think there's a men's health crisis going on, not just here in this country, but globally. And this is really a part of the solution in a preventive way, a virtuous cycle way. And again, I think frankly, it's just education, right? Whether it's a solution for everybody or not is to be seen. But I think what we're trying to do is go out there and really educate day in and day out, and give people the tools to make the decisions that they need to make. And patients first, right? Providers will catch up. I think patients more so than ever are out there seeking information and seeking help. So, happy to fill that gap to whatever degree we can.
Yeah, awesome. Yeah, I definitely want to dive into some of the myths and misconceptions because I certainly have some. um,
Mm-hmm.
but maybe elaborate a little bit more on the distinction between injectable exogenous testosterone TRT versus an oral delivery.
So yeah, I mean, on the face of it, obviously there's a convenience aspect, right? Injections, people are often doing. Historically, they were doing them IM, sticking them deep in the muscle. That's moved to primarily sub Q, so people are taking these, in the belly. But again, frankly, how many people at the end of the day are really willing to take an injection? So I think oral came along, not it did solve and does solve this convenience or fear of needles aspect. But there's also this new paradigm of evolving in terms of mimicking the daily circadian rhythm. So, testosterone is made by your body every single day. When you go to sleep, that's when your hormone systems are really activated and producing. So when you wake up is pretty much peak testosterone, and then that's declining throughout the day. So what orals are able to do is more closely mimic that natural circadian rhythm. And that's really where we start to see more than what we had originally honestly anticipated when we were in the development phases of sort of oral versus injection. Now, as this is, KYZATREX is our product, has been out in the wild. We're starting to see a lot of those differences truly come to light and sort of manifest in terms of both efficacy and safety as it regards to the patient.
Well, what about the oral delivery matches the circadian rhythm versus an injectable?
So, good question. Technically, I mean, you could replicate this with an injection if you took an injection every single day, right? So the what you get with an oral is it is short acting. So the way that the formulation is designed for a day. So you're not getting levels, and your body will use that. The half-life is 4 or 5 hours. So by the time you're done with your day, the testosterone is pretty much flushed through your body, and then your endogenous system kicks back on when you're sleeping, saying, hey, look guys, we're deficient here, let's get back to work. So again, injections often, and a lot has been learned, right? If you talk to a lot of providers today, when they used to do injections for one injection every 2 weeks, now they kick themselves saying, why the hell were we ever doing that, right? They were like, that didn't make sense. So the timing intervals have gotten shorter, which is good. But again, the real question is how many folks, and not even just how many folks are going to inject themselves every day. Cypionate's half-life is much longer. So you're by nature, you're going to have like residual effects in your system with that injection versus an oral.
Fascinating, man. I'm already learning a whole bunch. It makes sense to me. And I assume that because it's formulated to be taken every day, the dose must be smaller. So if you're matching that circadian rhythm, that natural peak, 9 or 10 o'clock when you get up and get going,
Hmm.
with a shorter half life and a shorter tail. Um, that makes sense to me rather than bombarding and then waiting a week and then bombarding again.
Huge
That
boluses. Exactly.
right. Yeah. Well, I'm. This is especially interesting for me, and I think a lot of listeners who are, my core demo is, 35 to 55-year-old males, right? And so, you know, that I do jujitsu, really religiously. A lot of my friends are, jujitsu players or, former professional athletes and guys that want to still get the most out of their life and their hormones, and they love to live, an active lifestyle. And so I'm like right on that fence, and I keep telling myself I want to delay the exogenous hormone treatments for as long as I can. I'm going to do ice baths. I'm going to do variable resistance training and fasting and stuff, and to try to delay that as long as possible. Um, so many questions. One question is, because any person's individual testosterone number is unique to them. Some guys do great at 550. Some guys really need 850 to feel like themselves. What is the process that you guys would go through to determine, like, okay, Sean, you want to be in like the 750 kind of range. That's optimal for you. Like, how do you distinguish between what is right for every given person?
Good question. So I think, and right, it's morning when you wake up. Historically, I wish providers and even patients were measuring their testosterone levels from their normal days, right? Like, say we were 30 years old, and you say, all right, let me get my T level, just like you probably, if you were going to a primary care, then like you got your cholesterol level and you've tracked this throughout your life. I think that if we could go back, or for guys listening today, I would start there and say, okay, let me start demanding this test because I should know it. It's cheap, and there's no reason I should not have it. So this way you can track your own testosterone as you age, frankly, right? That would be the best solution to say, okay, this is where I have been, and this is probably where I need to be. That's, again, individualized, best way to know that. Outside of that, for folks that are now, again, because the topic is becoming much more prevalent today and understood, they're kind of coming into it a little bit later, saying, okay, now I might be 40 or 45 or 50, and I'm feeling these symptoms. My T level is X, so I don't really know where I used to be. For a lot of those folks, I think what is the beauty of testosterone and oral testosterone, two things. One is it's still titratable. So you can come in, there are different doses to match an individual needs. You can start lower and titrate up. Some folks choose to start honestly at max dose. We've seen this happen a little bit more in the oral testosterone space because the safety profile is it looks cleaner from a lot of the real world data that we've seen. Things like elevated hematocrit and again suppression of your own system, they don't happen as much. So you have physicians and patients have a lot more confidence to go up to a higher dose, just to ensure symptomatic relief at a faster clip. But again, then you really react and see how you're doing. It's a balance of a couple things, right? How am I feeling compared to pre-therapy, right? Not necessarily where I was when I was 30, but just before I started therapy, how am I feeling? How do my numbers look on paper? And I'll talk about free testosterone in a little bit because that's really unique when it comes to oral testosterone and sort of the mechanics behind raising free T. And then what do my safety parameters look like, right? What are the typical safety things that we should be monitoring with testosterone, and are they in line? So you're balancing that efficacy and safety side. And again, historically with injections, that was a really, let's call it intricate dance, because because of these levels that you were getting pretty high, super physiological, it just had this cascading effect. Fortunately, on the oral side, you really don't see that, again, in real world data. So it's a lot easier for providers to manage, which is nice, right? Again, it invites a lot more people onto therapy to say, hey, look, am I going to be doing better than I was doing before?
So you can really kind of attack it from two different directions and maybe talk to your doctor I assume you guys do virtual consultations and align with the
So
doctor to
we
get
have a
that
number of
script.
partners. Yeah, we have a number of telehealth partners that can do virtual consultations. Of course, you're always doing blood work. I think again,
Yeah.
you gotta understand where those numbers are, both your total T, free T, SHBG, and then things on the safety side as well.
So if somebody's like, okay, maybe it's an individual person's decision or a decision that they collaborate with their doctor on. They say, okay, I want to step up. I want to go slow and I want to get up slowly and then find that sweet spot where I feel good, I sleep well, libido, all those other sort of benefits that people get, mood
Yep.
stabilization, which is a big deal. I know that. Or I can go big and say, cool, let's just, I'm doing it. I'm going to go big and then I'm going to titrate down. Is that really up to the individual in the consultation with their doctor? And what's your experience between the distinction of those two approaches?
So yeah, it is definitely up to the individual and the physician or the provider. What we've seen more often than not is again for two reasons. One is you get people switching over from injections. So because of that previous injection exposure, which is almost always at super physiological doses, because not intentionally per se, right? But when you're taking an injection that is even lasting a 1 week period, those first couple of days, you are going to be above normal, right? That is the only way that thing is going to last throughout the week is initially you have to be above that average line, right? Because then later in the week, you're going to be below the average. And that's how you end up in the middle on paper. So if you have someone that's coming from therapy on that side, because of that reason alone, you often see providers start at max dose
Hmm.
to help with that transition. But we also see it honestly a lot on testosterone naive patients. Again, because the symptomatic relief is effective, and we just live in, hey, let's get there now. I want to again, whether it's optimize, correct, whatever the reason might be. And then if the safety profile looks good, that you really don't need to, you really don't need to titrate as much. So even in real world, right? Again, always up to the patient and provider. More often than not, that we see people on that max dosage.
Interesting. Super fascinating. So now let's dispel some myths because you already said something that I was like, what? You mentioned that with the oral application, you take it in the morning and that matches the natural, expression of hormone optimization that starts at, 9:30 or 10 a.m., whatever. What you said was that has a shorter half-life, which allows your own endogenous testosterone to kick in the afternoon and into the evening and overnight, where we're doing muscle building and we're doing brain cleanup. I was under the impression that if you take an exogenous testosterone at all, that hijacks your endogenous testosterone production, like full stop. Is that not true?
Yeah, not exactly. So, well, that is true again when you are taking these super physiological doses, right? So let's stay there for a second, because effectively you're taking a dose that's lasting for a multi-day period. Even again, take it at even if you're going to do it twice a week, right? At the end of the day, you still have a multi-day period where you have this exogenous testosterone that's flowing through your system. Then yes, during the time where your body would normally produce hormones, it's telling itself, right? The body's smart. It says, we don't need to, we got enough. Do not go to work, right? So, and that's why you see things like testicular atrophy, because the
Right.
testes are actually not producing. And if you look at LH and FSH, those numbers on injection therapy are often undetectable, right? You will not find those numbers on injectable therapy. On contrast, when you look at oral therapy, and to be clear, it is BID. So you're often taking this twice a day, morning and again in the real world we're seeing a morning and lunch. Personally, I take it at morning and lunch to again more closely mimic that curve. But you look at again the blood parameters, and LH and FSH, while they go down, they are often in the normal range, lower end of normal, but often in the normal range. Testicular atrophy, I've really not seen it reported. So it wasn't in our trial data, and again, real world, at least has not been brought to my attention by providers. So, and personally have not experienced it. So your system is actually still on, right? And we
Mm.
kind of, I use the analogy, like imagine you have a factory, right? Your hormones are a factory, you got workers, you got equipment and whatnot. So when you start an injection therapy or you're on an injection therapy, you are shutting down the factory. The workers are going home, the equipment's being shut down, full stop, right? Locking up the door, done. Versus on oral therapy, you might be sending a couple of the workers home, you're shutting down some of the equipment, but you're still running a couple shifts, and the factory's still on. So implicitly, also when you get off, there's not as much work in starting back up because you were doing some of the work along the way. You haven't, again,
Mm.
it's not, everything's not dusty. So I think that's an easy way to look at the comparison between the two. And again, what happens when you're on, this does change the paradigm on what happens
Yeah.
to your body on exogenous testosterone.
Yeah, I mean that's all brand new news to me. That I mean for a guy like myself who I think, it's a matter of time before I do it. It makes me feel a lot better. And you've given me the education to understand that you're taking, with injectables you're taking larger, would you say physiological, would you say
Super physiological doses.
super
Yeah, exactly.
physiological, yeah, which I think of just Superman. You're taking Superman doses a couple times a week. That's just like boom, blowing up and then coming
Way
back
up.
down, and then everything's shut down. Versus yours, which is shutting it down for a little bit, but not totally shutting it down. I mean, wow, that's really interesting.
I'll
Um,
just add something there, Sean, too, because and that's why we're actually running a pilot fertility study. So we're taking it in younger guys that have healthy semen, and low testosterone, and giving them KYZATREX, and seeing what happens to that sperm count. And again, this is a pilot study, so 20 patients overall. I think we've had about 5 through that, at least the data has been published in an abstract. And 4 out of the 5, 80% of them, actually their semen parameters remain normal. So again, contrast to what we know about therapy, um, they are remaining in that normal range. So I think it actually introduces a really interesting paradigm, for the future, for again, because testosterone deficiency is affecting younger and younger males, right? Whether it's
everybody,
it's it's again
everybody.
lifestyle, food, environmental factors, right? Like this barrage, and we also know, right? Like total T levels decade over decade are down, no question about it, right? Each generation has lower and lower testosterone levels. I would be, it would probably be extremely eye opening. You just go to high school and test 100, high school seniors, and look at that level today. And I think, it would probably give a tremendous wake up call, to everyone, saying, look what's happening.
Yeah, yeah. Piggybacking, yeah. I mean, again, the fertility issues, across certainly the United States, but across the world. Yeah, I mean, we're just softer. We're just softer, weaker, whinier, you know, fractions
Yeah,
of our
look at military
grandfathers.
recruitment, right? Like
Yeah,
how many people really qualify for US military today, right? 18-year-old guys. I think I don't even want to quote the number because it was so shockingly low. Um, that's a
can't hack it.
problem.
Yeah,
Yeah.
can't
Yeah.
focus, can't work, can't grind. Moody, whiny. Let's build off of that. So, what do we know about the sort of non-superficial, right, aspects of low testosterone? Because when we think about like why someone might be motivated, maybe it's because it's libido, maybe it's mood, but I think a lot of guys, they just feel flabby and tired and they want to look
Hmm.
good in their underwear and feel that libido increase. But what can you tell me about what some of the very serious health issues are associated with sort of chronic low testosterone?
Yeah, so this is well documented, study after study and large ends, right? So whether it's a few thousand patient study all the way to, I think there was a VA study that was like 143,000 men that looked at all cause mortality, being significantly higher for men that had testosterone deficiency. So this is some of the best research that's out there on a disease state unequivocally. And I think again, it's surprising that it's not been talked about more. So I think you can even start right top down. Um, Literature will show at the brain function, right, that there's increased tau proteins in testosterone deficient humans. So tau proteins are tied to Alzheimer's and dementia. Often the target of new pharmaceutical interventions are targeting and trying to reduce those proteins. So data there, obviously, so there's an implication there. Um, Go further down, cardiovascular risk, right? This has also been well shown that if you're testosterone deficient, increased levels of cardiovascular risk. And I think that's, from things as specific as like left ventricular function all the way through endothelial function, right? Like what's happening to your blood vessels and how well are they functioning? And it actually, well, I'll still keep going down the body, but at the end of the day, there's an androgen receptor on every organ in the body. So we know that there's an implication here across the board. This is not just, again, as you mentioned, libido specific or muscle building. I think, yeah, historically it was only thought muscle building. The good thing is now that more and more people understand how important muscle is to overall vitality, longevity, muscle as an endocrine, secretor, what it does, right?
Metabolic.
So yeah, exactly. This is all metabolic health. So, which is a relatively new concept, if per se, but it has a role there. Bone density, right? If you look at both male and female, osteoporosis or osteoarthritis is a
Mm.
big issue, and testosterone deficiencies directly correlated to it. Um, yes, again, libido, urological conditions, and so forth. So again, you're kind of going across every major organ system in the body, and there's a lot of good research that will link what testosterone's role is to that function.
Yeah. I saw some statistic yesterday talking about a tidal wave of osteoporosis and sarcopenia stemming from GLP-1 agonists, right? I'm super heavy. I got prescribed a GLP-1 agonist. Yeah, I wasn't hungry. I lost a bunch of weight. But like I'm spraining my ankle walking downstairs and I don't have the muscles to like walk for longer than, 10 minutes. My thought is maybe there's a connection here, an opportunity here that maybe fellas, rather than taking a GLP-1 agonist, 50 years old, maybe you're 60 pounds overweight, you're sluggish and tired and moody and ineffective and you have brain fog, maybe rather than taking a GLP-1 agonist, which is going to drastically affect your bone density. Your bones are going to be brittle, and you're going to lose mass, not just muscle mass. You're going to lose fat, muscle. Um, maybe a better option is to increase your testosterone so that you have that get up and go to go change your lifestyle, to move, to lift, to run, to stay focused on your tasks as an alternative to what we now know unequivocally is pretty damaging to the body.
Absolutely. So, right, I think you mentioned that virtuous cycle that guys need to get into so they are active and doing the things they need to do. So, yeah, you're not going to get. I think GLP-1s, obviously, speed has been a huge attractive feature. But I think there's a couple things, like as you mentioned, like again, the muscle mass loss is tremendous. This could be up to 40% of lean muscle mass, which is lost. Again, could be properly managed with the right protocols and guidance and so forth. But again, we have to look at the raw, like the mass population. They're not doing that. So they
Right.
are experiencing that. And then the adherence is so short. Once you get off therapy, if you don't have that right guidance, you regain that weight, that is actually fat gain. It will not be muscle, right? You're not going to go back and put on the same muscle you lost. It's actually going to be harder. So you actually net in a worse place after therapy, potentially, than when you started. So muscle preservation is key. And I think if you look at testosterone therapy, yeah, it's not a quick fix. And again, not by no means are we indicated for, muscle preservation and whatnot. But so Marius is actually going to be running a trial looking at KYZATREX and GLP-1 semaglutide to start, and then looking at semaglutide alone, so we can start to demonstrate what that difference is, and what testosterone's role is, because GLP-1s are not going anywhere no matter what, and they have the right, they are a tool in the toolbox. But so what can we do, and how can we guide patients better to ensure, again, outcomes, long-term outcomes, whether that's 3 years, 5 years, 10 years from initiation of these therapies, that we're actually increasing their health span, because they still have that all important muscle on the body.
Yeah. 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 I think, when you think about it as, okay, if I can get my testosterone numbers up with a little bit of help, then I'm going to be more motivated to make the lifestyle changes that will help me into my later years. I'm going to be, I'm going to feel, have more energy. I'm going to have more focus. I'm going to, grab all the groceries in one trip like I used to do, to take them out of the trunk, rather than having to take 4 trips, because I feel motivated to do so. Um, that to me is an amplifier of of a lifestyle and habits and actions that make more sense. You're going to be better off in the long run if you can get those numbers up, rather than some other sort of intervention that undermines, your longevity or your resilience or your physical capability, right? Yeah, that's really interesting.
I think, and so you kind of make a good point, right? Again, like back to virtuous cycle and general health. I think something different about us, we why we're so passionate about this is because it's a core foundational health aspect, right? Full believer in exercise, nutrition, sleep, and stress management, or mental management in that sense, right? Those are 4 sort of non negotiable pillars. But at the end of the day, if you're struggling and you need to fix this, because there's this imbalance, right? If you have this imbalance, then you may struggle. If you are able to fix that and get in this virtuous cycle and improve upon those 4 other pillars, and maybe you do a 180 in your life and whatnot, and in 2 years, 3 years, 4 years, whatever that might be, you go back and look, maybe you get off therapy and your numbers look fine because you reduced your adipose tissue, and maybe you cut out some of those toxic habits, and you're sleeping better, and you're able to produce your hormones. The environmental factor, I think, is going to be tough, right, for our entire population, just because it's so embedded. But like, I'm rooting for you. I think that's great, and I hope a lot of people can do that. It's just it's not going to be possible for everyone. So
Yeah.
you just got to support them as much as you can, and kind of like we were talking in the beginning. It's like it's up to each patient, and we're trying to just give you the best tools to have the best health journey you can.
Yeah. On that note, the best health journey that you can, is there a I know that it's everything is individualized. It's up to the person and what their sort of goals are. I have this notion that you only want to take something as long as you need to, right? That minimum effective dose, right? So, um, let's say you begin oral TRT treatments, you get your numbers back up, you get the gas in the tank to change some of your lifestyle, and work feels good again, exertion feels good again, and maybe you do it for 6 months, or maybe you do it for a year, or maybe you do it for 3 years. How much of a consideration is there for people who want that minimum effective dose? They want that little amplifier that they can use for the shortest amount of time possible, so that they can get other things in order, so that they don't have to be on it any longer than they need to. Is that thought about, considered during all of this?
So I think it goes into a more individualized patient, question and journey. But I'll lay it like this, at least using some, data, especially as it relates to, because obesity and testosterone deficiency are so intertwined and bidirectional. I think, some of the data will show, independent of testosterone therapy, if you lose say 10% of your body weight, you can have, I think it was, I believe, like an 80 to 100 point testosterone increase. And then you take that up to like 15% plus, you could even see like a 200 point increase in testosterone.
Wow.
So, I think, like, take the average US male, if he's 200 pounds ish, right? So he's got to lose 20 pounds, 20 to 30 pounds to achieve that. Right. And I mean, again, like, not getting into body comp or body fat and so forth. Even though, right, most probably the average US male is probably like 28 to 30% body fat, which is definitely on the higher end. So, if you're able to do that, say lose that 30 pounds and get your numbers back to a normal course and feel good off of therapy, like, I think that's a win at the end of the day. But that's probably like the barometer, if I'm thinking in my head, like what you need. But then also, honestly, flip side, you have to look at symptoms. So you may, like we said when we started, like, what was my feel good level? What was my average for me? Was that 700-800? So even if I'm a 200, I jump to a 400 through lifestyle changes. Am I there? Right? Do I have the symptom improvement that I need? That we don't know. But again, I think
Probably
it's
not.
always worth the reevaluation, right? Like, go and see. Like, I'm a big proponent of regular blood work, right? I draw blood 3-4 times a year. Like, again, they're great barometers into how you're doing and what you're doing, right? Like, a lot of people take this approach, like throw the whole kitchen sink at it, but you don't always have to do that, right? You can introduce a few things, see how they go, tweak, your protocols, and then progress, right? So then you can tease out maybe what is working, right? Not always the easiest thing, right? If you're feeling good, then often I personally just, try to keep everything going. I don't need to know specifically. I think what certain things are supposed to do. And if again, overall the equation feels like it's working, I mean, frankly, I continue.
Yeah. Yeah. What are, anecdotally, or do you suspect, does your product act synergistically with? Have you seen the introduction of like peptides, BPC 157, or other things? Like, does it have the same or a better synergistic effect than the injectable version?
So we definitely have a very large cohort of folks that are KYZATREX plus peptides, right? Especially when you spend time in whether it's functional or longevity medicine, that the peptides are definitely just a key part of therapy. So I wouldn't say again, like, I like being able to reference data at the end of the day for validity. And we haven't run specific tests comparing, okay, we have an injectable version versus KYZATREX and how that interacts with the peptide. But I think if you take a step back and think about, even again, just use the word longevity medicine, right? You have these pillars that we talked about that are lifestyle related. Then really the next layer in a lot of senses is hormonal therapy, right? These have to be in line and working properly for that next layer of peptides to work properly, right? Peptides are amino acids that are, traveling throughout your body, trying to do their jobs, or precursors to growth hormone and so forth. But hormonal therapy is non-negotiable. So I think if you're able to fix that first, like for a patient, you're going to see significant improvements in what you're targeting, because again, the testosterone, the androgen receptor is on every organ, so you're going to see improvements. And we're actually in discussions with an early diagnostic company that looks at organ health and try to tease out, okay, where are we seeing the most improvements? And I think that's going to be really cool data for people that want to focus, again, specifically on certain organs, right? They're like, hey, look, my kidney might be behind. How am I going to focus on that health versus my liver health versus cardiovascular and so forth? So I think, the answer to your question in that sense is that there are absolutely synergistic properties, right? And if I can take the body and most physiologically restore those foundational levels, I'm giving my best shot at the course of therapy that stacks on top of that.
Hmm. Yeah, that makes sense. That makes sense. Well, yeah, I realize that was kind of an unfair question. If you don't have the studies to support it, you're kind of speculating. But I'm curious again because people that I know, listeners to this podcast, people listening right now, are thinking, well, do I go down the peptide rabbit hole first? Do I explore 4 or 5 different types of peptides? Um, which is harder to do now, right? With the regulations coming
With the
down,
regulations.
it's harder to find. It's harder to access. Um, smart people can figure it out and they get it
From
done.
the conversations I have with a lot of folks, and maybe a lot of the listeners will know, like Elizabeth Urith had a Boulder Longevity, right? Elizabeth's Dr. Urith's a foremost expert in this space on peptides and everything in between. A lot of these folks are not just using KYZATREX. They've historically used testosterone therapy. They're definitely using KYZATREX a lot more these days, and it's like the base therapy. You're going to be on it. I really haven't seen a lot of folks just use the peptides.
Hmm.
And
Hmm.
again, I think you're giving yourself the best shot at everything working well. I mean, again, personally, I'll share. I'm gonna do some content around this. So depending on when this airs, either the people will know it by then or not. But looking at KYZATREX, BPC 157 injectable, things like tesamorelin, right? Like going from CJC onto tesamorelin and looking at the differences in effects. I think my personal health journey is I mean, I'm sharing it, right? Because I think it's a lot of people are in the same place. Not just having testosterone deficiency and feeling some of the symptoms, but then how do I really optimize, right? Like beyond that. And because these things are kind of like sleeper things, right? You kind of are busy, you're in the grind, you're working, you're building, and you kind of look at yourself, or then you look at the blood work and you're like, what happened? Like, where did this happen? Because I feel okay, I look okay, but it's truly not reflected. So I have to imagine a lot of people are in the same boat when you kind of hit, stride in midlife. Like, it's hard, even though you feel like you're doing the right things. That's
Yeah.
the amazing part, because you really do feel like I'm generally eating well, I'm generally exercising, I'm generally doing the right things, but somehow it's not totally reflected in where at least you might want to be from an optimization perspective.
Yeah. Well, there is a big difference between normal and optimized, and again, it's individualized, but normal, a typical allopathic doctor that you talk to, where you're like, hey, I'm feeling kind of moody and weak and unmotivated. Can we pull my hormones? Most doctors are going to say no. I hear this
Yeah.
all the time. Like, no, we're good. You don't need to. And then you got to pretend cry with the doctor in front of you for him to be like, okay, all right, fine, yeah, maybe we should pull your hormone numbers. It's they're so far behind, you know, the sort of biohacking and exogenous approaches, because they in their mind 350 is like, fine, you're
Yeah,
good.
it's criminal, right?
No
Honestly,
way.
it's criminal. So we started I started a nonprofit around this space. It's only 2 months old. It's called the Testosterone Project, and one of the key pillars or objectives is that testosterone testing is part of the standard blood panel for every male over 40. So
Yeah.
this should be, again, non-negotiable. You're showing, because again, people like us and people like your audience, they know to go in and ask for it and how to advocate, or they go to doctors. They've already spent enough time and they go to the doctors where you don't have to, beg to get a testosterone test. But for, the millions of people that still are in that traditional healthcare system, this should be standard on the blood panel. Like, what it is, testosterone is actually the single most telling biomarker in your body, because
Sure.
think about it this way, right? You're testing your cholesterol. Okay, that's a view into your cardiovascular health. You're testing your blood sugar or your A1C. That's into your glucose metabolism. Again, blood pressure and all these other metrics, right? You're checking your liver enzymes and so forth. They're all individualized to a certain area of your body. Testosterone is telling you, like, how is your overall picture doing, right? Because if you're deficient, you may have some cardiovascular issues, you may have inflammatory issues, and the list goes on, right? So and it's not expensive. Why would I not have this test done?
Yeah.
It shouldn't have to ask for it. And so that's one of the initiatives of the testosterone project.
Testosterone project. Yeah. It's really sad. It's really sad to know people in my life who are really struggling, and they're not on my end of the spectrum as far as, N-of-1 studies and biohacking and really taking a deep dive into their own blood work and their own health advocacy. But they get really discouraged when they're turned down and told no, like, no, we don't need to pull it. Or when they do pull it, the doctor says, you're at 380, you're pretty good. Like, nobody wants to be pretty good, especially
Yeah.
if you are a highly motivated individual, who likes to play sports and likes to live an active lifestyle. Um, it's like a kick in the nuts being told, like, you're fine, it's good, or no, we're not going to test it. So I mean, here on the testosterone project, I think it's essential.
It's gotten
uh
even worse with reference ranges, right? Sometimes you're at,
right.
220 and they're like, you're normal. That's
Ugh,
that's even worse.
brutal. That's brutal. That's so sad.
And
35 year
people
old
don't
guy
question these things. They don't
shows
really
up
know.
and
Again, yeah.
220. Like, dude, you got a long road ahead of you. You got some issues, you know. um is it true that you guys were the first FDA approved oral application?
So we actually were not the first approved. There were actually three in development around the same time. So KYZATREX, it's interesting because in our development pathway, we did a lot of firsts. There were methods around, how you test for this in serum tubes versus plasma tubes, how we introduce things like real world diets, right, to understand, okay, do you have low fat, medium fat, high fat, meals. So we had a lot of first in our development, which I think led to the best development program and package. But there was another company that did get there, ultimately got there first, but we are the only one that got approved on its first shot. So I think
Mm,
that speaks really volumes to the quality of the data that we produced.
nice. You nailed it. um let's talk about the ladies. Let's talk about the ladies and testosterone for women. What sort of opportunity or what sort of benefits could women potentially get from KYZATREX?
So again, KYZATREX, just disclaimer, right? Only indicated for males with low testosterone, not indicated for females. So I think this is a super important area to research, and produce that data, both frankly just for that female population, and then I think back to testosterone project, FDA approved testosterone for females should be a thing. There should not be barriers put up by regulatory agencies to get this done. So that's again one of our missions. But I think it's really simple when you think about the female physiological state as well. Often testosterone has been touted in females for, again, libido and hyper function sexual dysfunction. That's been in guidelines and pretty thoroughly discussed. And actually, there's a New York Times article on this earlier this week, and there's a lot of good data around that. But at the end of the day, the female is not different than the male. There are androgen receptors all over the body, so you can really draw the same lines, whether that's cognitive, whether it's cardiovascular, whether it's bone health, whether it's muscle health. These are all the same aspects for female. So again, it's really disappointing, honestly, when people only relate it to sexual function, or just blanket dismiss it, right? Because actually, females premenopausal have about 4 times as much testosterone in their body as they do estrogen. 4 times.
Hmm.
So, people regard estrogen as the female hormone and testosterone is a male hormone, but males need estrogen too. That's important for us, and females need testosterone, and that's why that level is 4 times as high. Unfortunately, again, through menopause they experience more of a cliff than males do, so it's a big shock. But again, back to what it affects for the female, uh, again, pending research, further research, but there's no reason to believe that there's any sort of different function in that female body than the male.
Yeah. What are some other exogenous testosterone myths that you hear all the time that people are just way off?
I think a big one, especially as it comes to oral, is liver toxicity. So old versions, and actually, so old versions, methylated testosterone and whatnot they were liver toxic. So that's why they never took off. The first testosterone ever like conceived, actually, this is back in like 1930, actually wasn't oral, but it was liver toxic. So it never worked. Next generation oral testosterone, like KYZATREX, is absorbed lymphatically. So that means through your small intestine. And that's a huge, I mean, again, it's the reason why this can work and this can be used across the board. I think that's a big myth that's being fixed out there in the real world. This has got to get fixed in a lot of the forums, whether it's biohacking, whether it's bro science or whatnot. Like, again, it's taken a bit of time, but it's again, it's starting to get fixed.
So does that would people benefit from really minding their lymphatic system with taking KYZATREX, whether it's a rebounder, vibration plate, or the big six like lymphatic massages? Do you think that does anything to help circulate the product through the body?
It's definitely an interesting premise. I can't say that we've or at least I've had those discussions with folks that are trying to, because at the end of the day, if you you're supposed to take it with food, and if you follow those instructions, like, you will get good absorption, right? For 9 out of 10 or 9.8 out of 10 people. So there's really no need to do anything beyond for drug absorption itself, right? Other benefits to lymphatic system, obviously totally fine. But truly, as it relates to this and what, the goal of therapy is, you really don't have to do anything. You can, and that's why it's, again, honestly, it's beautiful for, like we're talking about, these virtuous cycle people that really just need to, hopefully get into gear. You don't need anything special. You just follow the instructions, and most likely you're going to be just fine.
Yeah. Yeah, the reason I asked that is it's become clear to me. I get the opportunity to talk to experts around the world in various different degrees and aspects of health, and we sit. You and me are sitting, and we're gonna be sitting probably most of the day today. And what I have found anecdotally for myself and my family, and also some of the people who have done a dry fasting protocol with me recently, is the importance of that lymphatic flush to be able to move that lymph around the body, because it does get stagnant in the back of your knees, gets stagnant in your armpits, and so that movement, gently bouncing up and down, rebounder, walking, vibration plate, you feel your circulation improves, you feel more limber, you feel more liquid, just better off, feel like your body is functioning at a higher level. So that's why I asked. And then when you said it's through the lymphatic system, I thought, well, shit, imagine taking your dose and then going on a rebounder for 5 minutes and just watching it uptake either
Uptake
more
higher. No, I
fluid or
think it's
faster.
absolutely a possibility for sure. And I think, kind of more to the premise of, like, we're sitting all day. So, right, the concept of these mini, exercise breaks and movements throughout the day, right? Instead of taking that 30-minute walk, which is great, right? Obviously, if that's what you're going to get in and that's the best, fine. But if you're able to take a 5-minute walk every hour on the hour, the data is actually showing that that's going to be more beneficial to you. So I think it's coincidental, right? It goes back to this concept of everything that is more in line with circadian rhythms or natural rhythms, like, that's in these bite-sized manners are actually what your body wants, right? Like,
Yeah.
do it, frequently and in short amounts. That's going to be the best for your body.
Yeah. Move, sucker.
Yep.
What do who's this not for?
Who's it not for? So, you know, it's interesting. I think what we see from patient success stories, I think you're going to see the people that are not going to do well are honestly the folks that are on super physiological doses and just must be there, right? Because they've been on exogenous T for like 10 years. They're used to, I don't know, 200 milligrams of cypionate a week and maybe walking around at 2000 nanogram per deciliter level. My hunch is it's not going to be for them. It's just they're used to that to those levels. Though that's really honestly, and that's a small group.
Yeah,
I
who's
wholeheartedly.
walking around at 2,000?
Well, if you're taking again these
Bodybuilders?
two, exactly right. I mean, if you're really in just that's your only goal, and you're not really thinking about overall metabolic health. Yeah, because think about it. If you're taking that injection, even if it's for 1 week or 4 days, right? You're absolutely at 2,000 nanograms per liter. If not, I've seen data like at 3 to 4,000 post injection. So,
Hulk?
you
Who, the
know,
Incredible Hulk?
yeah, just I mean, honestly, I bet you it would surprise us, like regular folks that are just on high doses. Um,
Whoa.
so, and that's not again, it's not what you want for a mass population, right? I think the point of and even for testosterone therapy, because we know how beneficial it can be for sort of this broad population experiencing this decline, right? You want patients that have never been on testosterone therapy to understand it and say, again, if I'm deficient, try it, right? Like we really want to get past this sort of steroid notion, right? And I think there's a couple things that play into that, right? You have, again, it's a controlled substance. So, that is a barrier to both patient and providers. And they're thinking twice about that. And I'll circle back to that in a second. And then on top of that, generally, historically, it's been an injection, right? So you take an average guy that might be feeling like absolute crap, has low T, should be on therapy, and then you say, okay, here, take this injection, right? This guy's, and so he's forced to go home and do this, and he's thinking, man, I'm just going to inject this steroid into me. Like, who am I, right? Like that shouldn't be in most people's minds. So again, back to testosterone project, one of the most important prongs, the third prong beyond testing in female, is descheduling testosterone. This should
Hmm.
not be a controlled substance. It's the only hormone that is controlled. It was done by Congress in 1990 as an outcry to the Olympics when U.S. lost the 100 meter, and again, only compound that's been controlled in this manner and only hormone to do so. Totally, it makes no sense.
Is it controlled everywhere in the world, or is it just
No,
US? Or
that's a good question. It's not controlled everywhere in the world. Most of the world, it's not. So again, why here? And a lot of European guidelines and whatnot, they've been much favorable to the whole therapy. Back when 2014, there were a couple studies that came out. Actually, the studies came out in 12, 13, but FDA actually refuted them and whatnot. But then they changed the labels and put increased cardiovascular risk on the
Hmm.
labels. EMA, same, FDA equivalent over there, did the same research and looked at the same studies and also understood they were totally bogus. They didn't do it right. Total,
Hmm.
panels of experts all came together saying this is not right, etc. And again, it just here in the U.S. they just clamped down. And honestly, I think it's because testosterone is cheap relatively and it's effective. That's not good for big pharma.
Yeah, buddy. There we go. I was waiting for that. Yeah, I mean, you can't help but put on your conspiracy hat when you're like, wait a minute, this is affordable and effective. This is going to make people healthy and strong. Ooh, yeah, that's not good for
Absolutely.
greater pharma's bottom line. Well, now you got Bobby Kennedy in there, who,
Mm-hmm.
I'm sure you guys had a company party when as he goes through the confirmation hearing, because the dude is, a specimen, and he's dropping methylene blue in his water on the airplane back
On
home.
Yeah.
Yeah. Well,
No,
yeah, I
it's
mean, I
great. I think it's the right move. Right? Absolutely. And I think
and
the
he's talked specifically
administration,
about testosterone. He said
yeah,
testosterone, psychedelics, peptides, these things need to be drastically deregulated because these help people, and let's cut the shit. So I'm optimistic.
Yeah. I mean, again, you look at the benefits and then you look at the safety profiles, right? They're so good. And they're not abused, right? Yeah, we can go on for sure on why, and they've been clear to clear-eyed folks, but been restricted bureaucratically.
Yeah. What do the haters say?
Um, I mean, again, off the bat, oral testosterone doesn't work, right? Like it just says it doesn't work, and it's going off these old notions of old products. Again, it can't get through. It can't get through the stomach. You'll not get high. You won't get adequate levels. These types of things, but again, that's why I invite them. Like, try it, see it if it works. And I think we've made a lot of skeptics. It's funny because a lot of providers that we work with, there absolutely was initial skepticism, right? Because they've never had experience with orals. You have these old ones that did not work or caused issues. So, rightfully so, there was some skepticism. They're like, okay, you developed the drug, so you only have one thing in mind. But I think the way that we've approached it so differently in terms of, again, importantly, access for patients, talking about the therapy as a whole, looking at metabolic health. I mean, how many CEOs are going to come on here and talk about it this way? Right? I don't know. Probably zero other ones. I think
Probably.
we have this broader vision, and this, again, this is a really good tool in the toolbox. So we've converted a lot of skeptics, but it's kind of a one by one thing, and then it just gains enough steam. So,
Sure.
not discouraged by that by any means, but absolutely invite anybody to try it and let us know what they think.
Yeah. What's the price point range that you can share with us?
So usually we see, because a lot of KYZATREX programs are wrapped into, like, whether it's telehealth or TRT clinics or wellness concierge, practices, usually we see somewhere like $2 to $2.99 per month.
That's it?
That's generally where we see it.
No
Yeah, and that's all
way.
inclusive. That's all inclusive, right? That's usually the provider saying, okay, here are your labs, here's your visit. That's not just drug cost. Um,
Wow. I was not expecting that.
yeah,
Wow.
that
I,
that's
I
that
think that
the goal
I
is
think that
access.
that's I mean, do you get big eyeballs like I just gave you when you talk about that,
Yeah, it
that
actually happened. I don't know if it was this morning or last night. I was speaking to somebody that I did not expect that. Um,
yeah.
so
I
we've
was
taken.
definitely expecting north of 1,000.
Yeah. No, I think, look, we've taken this approach to be sort of patient facing, increased access, and that's why we did not go through insurance and PBMs, because we said this thing is going to get blocked all day. We're going to have
Yeah.
to increase the cost just to rebate it back to the middleman. And we're
Right.
not, again, we took a different approach. We did not want to do that. We said, we know how many people, 25 million men in the country, are testosterone deficient. If we go this path, we're going to have to price it at $1,000, and it's going to be for the few. Absolutely not, right? I think we want, and again, clinically appropriate, and those that are deficient and under the right care. There's lots of guys. There's the population is just too big. So
Wow.
it's turned into this passion project, and we really are about access.
Damn. That's really surprising to me. I mean, that, think of the people who take tons of supplements. They're spending $500 or $600 a month for expensive piss. They're not they're not doing, they're not doing blood work to show like nutrient levels. So they're throwing darts,
Mhm.
blind darts at a dartboard. I probably need, B complex, or I probably need that. And again, it's just, you're just peeing all of it out. You're not sure what's working. You're not sure to know that price point is what it is really surprising to me. Wow.
Yeah, you're just
Wow.
hopeful. And again, like, this does, our view is like, this is doing 80% of the work, right? You got to do
Right.
you got to do the rest, but at least from a supplementing perspective, yeah, I had a head of a large consumer health organization. We had this kind of a similar discussion. He's like, so you basically have a super supplement at that price point.
Yeah.
I'm like, that
Yeah, for real.
could be one way to, describe it. Again, it's RX, you need a prescription, but given the price points of what we see in the market today for, again, I don't want to say unproven, right? It's just different clinically indicated type things. I don't dislike that name.
Yeah, yeah. I think it's appropriate. Wow. Well, before I this is awesome, dude. I'm really impressed, Shalin, and I fall into that category of skeptical. Organic pine pollen, Fedosia agrestis.
Mm-hmm.
I'm doing the natural things, and it's been how long has it been? Maybe 4 or 5 months since I've tested my hormone levels. It's okay. But it's not where I want it to be, especially for the level of activity that I'm into. So, um, yeah, again, like I'm just really impressed. So before I ask the last question, and we'll take this thing home. Where can people find out more?
So I think the best place is go to KYZATREX.com, KYZATREX.com. That's the product website. So, very specific information there. We link out to some of our telehealth partners that can, take a patient through the process if they don't have, a provider that they're fond of. The other place I'd say go to rethinktestosterone.com, rethinktestosterone.com. And that's our disease awareness site. And that's where you'll find a plethora of information around the science, the literature, all of the studies that have been done in testosterone space at large. Because again, even type 2 diabetes, there have been amazing studies done around type 2 diabetes, and you scratch your head at why the endocrinology field is not using this as a go-to therapy. Yeah, you're going to need some metformin and whatnot, but this is going to help with insulin sensitivity, right? So it's not a question. It does, right? So like in our data, even actually our fasting insulin levels went down by 5 points, which is pretty significant.
Wow.
So again, that's the beauty of this, and why we're so excited is the research is so strong. We are not coming from, like, there should really not be two camps around testosterone therapy. The research really just fits into one camp. If you're testosterone deficient, there's a lot of problems that are going to happen, and if you replace it, there's a lot of things, a lot of good that can happen. Now, again, we got to do FDA studies for them and so forth, but I think the writing is very clear. So rethink
Yeah.
testosterone, I think, is awesome for people that just want a aggregated resource of things that have happened in this space in the last 20 years.
Well, what I'm struck by is how even-handed you're talking about it. You're not pitching, you're not advocating, you're not making outrageous claims. You and I are looking each other in the eyes, over Riverside, and the way that you're talking about it is very balanced. And I think that people who are listening or watching right now, um, believe you, and the way that you're presenting this information in a very measured, very thoughtful, very straightforward way, I think is going to aid in advocacy, for this product, because people like me and people who are you know a little skeptical about any sort of pharmaceutical, any sort of product that isn't organic bee pollen, or pine pollen, or whatever. Like, I'm convinced. I'm convinced, and I think that the listeners will be too. Um, so this is the final question, and this is the same question that I've asked hundreds and hundreds of times, to fill in the blank, and this can be based on really anything. It doesn't have to be specific to KYZATREX, and you can elaborate as much or as little as you want. Please fill in the blank. Everyone would benefit from knowing.
I'm pausing just to, it's a good one, and I don't want to lose, use the chance, or lose the chance rather. Look, I think everyone would benefit from knowing that this is an overall, part of your journey, right? I advocate. Yes, I am a testosterone advocate. It is not the solution to everything. It's a very important piece of the pie, but I can't, personally, I can't not also advocate for, honestly, these pillars that we talked about earlier. Like, look at your exercise, look at your sleep, look at your stress, look at your nutrition. I mean, personally, I've been so focused on a lot of these things, at least more so this year than ever before, even though this has been, or the last 12 months, even though this has been my busiest, ever. Right. And I think we're just actually going to get more busy considering where KYZATREX is on the spectrum of things. But again, you sometimes when you combine all these things and you think about your journey and whatnot, like, there's also this mental clarity that occurs, and honestly, it's beautiful. So the more people can think about it as just generally a journey, not a destination, like, I think that's the best thing I can share, at least.
Well said. Shalin, thank you so much for joining me today on the Optimal Performance Podcast.
Thanks for having me, Sean. It was a pleasure.
Okay, I'm going to keep